Our lecture today is about septic shock, and you are also going to talk about the Surviving Sepsis campaign guidelines of 2016. First, we're just going to give a clinical definition of sepsis. Systemic inflammatory response syndrome, or SIRS, is defined by two or more of the following criteria: temperature more than 38 or less than 36 degrees Celsius, heart rate more than 90, respiratory rate more than 20, or a white blood cell count of more than 12 or less than 4. Sepsis is SIRS plus an evidence of infection. Severe sepsis is sepsis associated with at least one sign of organ dysfunction, hypoperfusion, lactic acidosis, oliguria, or an acute alteration in mental status. Septic shock is severe sepsis plus hypotension, and multiple organ dysfunction syndrome is altered organ dysfunction in acutely ill patient. SOFA score is defined as now to talk about the timeline of the Surviving Sepsis guidelines. The first edition was in 2004. There were multiple papers that were included, and the Surviving Sepsis guidelines were based on. This paper, or Early Directed Goal Therapy, was published in 2001 by Emmanuel Rivers. The goal was to provide early care to patients who presented to the ED and were suspected to have sepsis or septic shock. It was pretty aggressive. As you can see, the goal was to first put central line and arterial catheterization in all those patients, resuscitate those patients to a CVP between 8 or 12, keep the MAPS more than 65, keep the central venous pressure of more than 70, and whenever these goals were achieved in the ED, to admit the patient to the hospital. All those goals were supposed to happen during the first 6 hours of resuscitation. One of the most famous ones, a randomized trial of protocol-based care for early septic shock, done by the process investigators. This trial was done to determine whether the early goal therapy protocol findings were generalizable and whether all aspects of the protocol were necessary. In this study, they randomly assigned patients with septic shock to one of 3 groups for 6 hours of resuscitation. One group was the protocol-based early goal-directed therapy. The second group was protocol-based standard therapy that did not require the placement of central venous catheter, administration of inotropes, or blood transfusion. And the third group was just usual care. The primary endpoint was 6-day in-hospital mortality. In this study, there were no significant difference in mortality overall between the 3 groups. It is important to note that this study was done 10 years after the early goal-directed therapy study was done, and most hospitals at that time had implemented a sepsis-based protocol. However, this study showed that protocol-based care, compared with usual care, resulted in increased use of central venous catheterization, IV fluids, vasoactive agents, and blood transfusion with no change in outcome. Now let's talk about the Surviving Sepsis campaign and the international guidelines for management of sepsis and septic shock. These were published in 2016. Now let's talk about the initial resuscitation. In the resuscitation from sepsis-induced hypoperfusion, at least 30 cc per kilo of IV crystalloids should be given within the first 3 hours. Following the initial fluid resuscitation, additional fluids should be guided by reassessment of hemodynamic status. This study shows that crystalloid should be the fluid of choice for initial resuscitation, and albumin, in addition to crystalloids, should be used only when patients require substantial amounts of crystalloids. An initial target mean arterial pressure of 65 should be obtained in patients with septic shock. This study, called high versus low blood pressure target in patients with septic shock, randomized patients with sepsis into a low target group with a goal mean arterial. Norepinephrine should be the first choice of vasopressor used in patients in septic shock. Vasopressin or epinephrine can be added to norepinephrine with the intent of raising the MAP or in order to decrease the norepinephrine dosage. In the case the shock is not resolving quickly, further hemodynamic assessment, such as assessing cardiac function with TTE or TEE, should be done to determine the type of shock. The sepsis guideline recommend guiding resuscitation to normalize the lactate level in patients with elevated lactate levels. There is also obviously a big emphasis of diagnosis. It is very important to obtain microbiologic cultures, including blood cultures, before antimicrobial therapy is given in patients with suspected sepsis. Antibiotics should be given and initiated within 1 hour after recognition of sepsis or septic shock. Empiric broad-spectrum therapy with one or more antibiotics. After a pathogen is identified, antibiotics should be narrowed. If a patient has a severe inflammatory state of non-infectious origins, there is no indication for systemic. The study suggests to use at least 2 antibiotics of different antimicrobial classes as the initial management for septic shock. It also suggests that antimicrobial treatment of 7 to 10 days is adequate for most serious infection. There should be a daily assessment for de-escalation of antimicrobial therapy in those patients. Concerning corticosteroids, the study suggests against the use of IV hydrocortisone to treat septic shock patients if fluid resuscitation and vasopressor therapy are able to restore hemodynamic stability. If this is not achievable, the use of IV hydrocortisone is recommended. The study suggests to use lower tidal volumes in adult patients with sepsis-induced respiratory failure without. Higher PEEP should be used in patients with severe AIDS. Prone position is also recommended. The study recommends against the use of high-frequency ventilation in adult patients with ARDS. This is based on a study called Now let's talk about glucose control. Insulin dosing should be started with 2 consecutive blood glucose levels of more than 180. This approach should target an upper blood glucose level of less than 180 rather than upper target blood glucose of less than 110. Blood glucose levels should be monitored every 1 to 2. Glucose levels obtained with point-of-care testing of capillary blood should be interpreted with caution, basically because these measurements may not accurately estimate arterial blood or plasma glucose values. If possible, the use of arterial blood should be done in patients who have. Talking now about renal replacement therapy, there is a suggestion against the use of renal replacement therapy in patients with sepsis and AKI for increased creatinine or oliguria, without any other definitive indications for dialysis. Enteral feeding should always be favored in critically ill patients over the early administration. The early initiation of enteral feeding rather than a complete fast or only IV glucose should be favored. Concerning blood products, RBC transfusion should be initiated when hemoglobin concentration decreases to less than 7 gram per deciliters in adults in the absence of extenuating circumstances such as bleeding, myocardial ischemia, or severe hypoxemia. There is also a recommendation against the use of erythropoietin for treatment of anemia associated with sepsis. Prophylactic platelet transfusion should be initiated when the platelet level is less than 10,000 in the absence of bleeding, or when counts are less than 20,000 if the patient has a significant risk of bleeding. Higher platelet counts, i.e. 50,000, are advised for active bleeding, surgery, or invasive procedure. Goals of care discussion should be addressed as early as feasible, but no later than within 72 hours of ICU admissions. This sums up our lecture for today. Please email me or text me with any questions. All the papers will be included in the ICU manual.